I have the pleasure to introduce to all of you. mm, I have the pleasure to introduce you Dr. Albert Borromeo. Dr. Borromeo is a surgical retina and uveitis specialist. He did his residency in PGH. He did his fellowship for surgical retina at Asian Eye, and he did his uveitis fellowship at Stanford. Um, Luckily, Dr. Borromeo has also actually applied for our department, so it's also very nice, Sana, to get us for all of you to get to know him. Hopefully, you'll get to be seeing him soon. So we're processing his application na muna, and then pretty soon he'll be holding clinic with us at Makati Med. Um, and Dr. Borromeo will be presenting a lecture on ocular syphilis, which is something we've been encountering quite a bit, unfortunately, this year. No? Albert,
Okay. Hello, good afternoon, everyone. So, it's really a pleasure, and thank you for the invitation to talk today. So, I'll begin sharing my slides. Okay. So, can everyone see the slide? Okay, naman.
visible.
All right. So, for today, we'll be talking about ocular syphilis. So, when you talk about uveitis, you really can't escape talking about syphilis, and hopefully, after today's lecture, we get a little bit more of the important things that we need to remember when we encounter patients with ocular syphilis. So, as a review, syphilis is an infection by the spirochete Treponema pallidum. So, it's a sexually transmitted disease, and that you can obtain either vaginally, anogenitally, or orogenitally. But it can also be spread congenitally, either in utero or during, or more rarely during passage through the birth canal. It can persist in an infected individual for an entire lifetime and reveal itself in various manifestations with symptoms capable of mimicking a great variety of diseases. This is not just for the eye, but for other systemic diseases as well. And because of this, it has been called the great imitator. And actually, despite increased public awareness, laboratory tests, and effective treatment, it still remains today as one important differential of many diseases. So I tried to search for the epidemiology of syphilis in our country. We don't actually have robust epidemiologic data with regards to our STDs, but some published international papers show here you have the prevalence of HIV and syphilis among men having sex with men in Asia. And as you can see on the left-hand graph, we can see that the prevalence of HIV in Asia is actually increasing. So this is in contrast to the worldwide prevalence of HIV, which is decreasing. And here you can see that in the Philippines, HIV is increasing, and it's um, logical to think that if HIV is increasing, syphilis would be increasing as well, given the similarity of the risk factors. So I did find this table, though, however, from the Quezon City Health Department, which shows the number of syphilis cases. Well, they said decreasing, but as you can see, syphilis is still one of the more common STIs that we encounter. So because syphilis has been described for 500 years before a successful treatment was available, so we know actually much about its natural history. And this is more for our internal medicine colleagues, but it's important for us to know this as well because in our history taking, we need to ask the questions so that we know what we are looking for. So the first stage of syphilis is a primary syphilis, and it is characterized by the lesion called a chancre. So the chancre lesion, which you can see here on the first picture, so that's a chancre on a tip of, on the base of a penis, and then on the bottom picture you have a chancre on the lips, and on bottom right picture you have a chancre on the neck. So chancres usually occur about 3 weeks after an infection, but this can range from about 2 to 6 weeks. So they usually develop in the genital region, but again, they can occur uh, anywhere where inoculation has occurred. So this can also be in the mouth or through tiny breaks in the skin. So these lesions have also been reported rarely in the conjunctiva or the eyelids. So these lesions are painless papules, which eventually ulcerate, and this is why most of the time patients don't notice it because there's no associated pain. So if you biopsy or culture these chancres, they actually contain numerous spirochetes, uh, and they usually resolve without treatment roughly 4 weeks after their initial appearance. So if untreated, the patients will eventually progress to the second stage of syphilis, which occurs around 4 to 10 weeks after the initial chancre lesion. So secondary syphilis denotes the stage during which spirochetes are become disseminated in the blood, and this is characterized by a generalized rash and lymphadenopathy. So as you can, so the pictures here show you the generalized rash associated with syphilis. So the rash is maculopapular and usually appear very prominently on the soles of the hands and feet because this is where we have a little bit more hypopigmented skin. But again, they can occur anywhere. So on the skin. So other symptoms may be very nonspecific. So fever, malaise, headache, nausea, anorexia, hair loss, and various joint pains, and even some nonspecific systemic signs and symptoms like liver, elevated transaminases, elevated urine creatinine involving the kidneys, diarrhea involving the GI tract. And eye involvement, it's usually not so common in secondary syphilis, only occurs about 10% of cases. But like the primary stage, these symptoms are transient and usually self-resolve over the next few weeks. So the following stage is the latent stage during which the clinical disease is neither detectable nor is the infection contagious. So this stage can last for an individual's entire lifetime, and we usually divide this into early latent, which is 1 year after the infection, or late latent, which is after 1 year. So some patients will progress to tertiary syphilis. So this one we don't see this very often uh, nowadays, mostly because of better treatment and available treatment. But historically, so tertiary syphilis represents an obliterative end arteritis that can affect most body systems, and they can have here the characteristic gamma lesion. So which can be found in the skin and mucous membranes. And when they heal, they form these really remarkable scars, which cause great deformities in various parts of the body for the patient. And also in this stage that things like cardiovascular syphilis involving the aorta, aortic valve insufficiency show up, as well as neurosyphilis. So for us ophthalmologists, perhaps this table is the most important. So in clinical practice, so we are taught that syphilis can occur at any stage, that ocular involvement can occur at any stage of syphilis, but it really does not happen in the primary stage, and it most commonly occurs during the latent phase of syphilis. So the ocular symptoms usually occur as late as 6 months after the initial infection, when many of the systemic manifestations have already resolved. So this is important because usually when us ophthalmologists see the patient, we just see the eye disease and we don't really see any other systemic symptoms because they're already in the latent stage of syphilis where the disease is asymptomatic. But again, sometimes they occur in the secondary stage, so you can still have the rash. But the message here is that even if you don't see any systemic signs, you can still think of syphilis. So syphilitic uveitis, because uveitis is actually the most common presentation of syphilis in the eye. So again, just to re-emphasize the point that many patients who present with ocular signs do not necessarily have systemic signs, and these symptoms can occur months to even years after the initial infection. So there are many presentations of syphilis, and we are taught this that syphilis is the great mimicker and can present with anything. So in the primary, if um if the patient presents weirdly in the primary stage of syphilis, it would be the chancres involving the eyelid conjunctiva, or there's even been a case report involving chancres of the lacrimal gland. Anterior uveitis and vitritis can occur, as well as episcleritis and scleritis. But an isolated anterior uveitis or even an intermediate uveitis is not really classic of presentation of ocular syphilis. So the more common presentation of syphilis would be a posterior uveitis. So this would be the entities highlighted in bold, necrotizing retinitis, chorioretinitis, or the placoid chorioretinitis that we usually see. see. Other not uncommon presentations would be retinal vasculitis and optic neuritis. And then for congenital syphilis, the most common presentation would be interstitial keratitis. So here is a picture of anterior involvement. So anterior uveitis for inocular syphilis is usually unilateral and can either be granulomatous or non-granulomatous. So the pathognomonic feature here are these iris roseolae, and they are relatively specific for syphilis, but honestly, they're also very rarely observed. So they are the dilated vascular tufts in the middle third of the iris surface, and you can easily identify them on slit lamp. You can mistake them for rubiosis, but usually these roseolae are much more broader compared to the typical rubiosis. And syphilitic anterior uveitis is often associated with increased IOP and is one of the important causes of inflammatory ocular hypertension syndrome. But again, an isolated anterior uveitis is not really a very, very common presentation of ocular syphilis. Much more common would be posterior involvement. So here we have posterior involvement involving vitritis, necrotizing retinitis, chorioretinitis, retinal vasculitis, and optic neuritis. So chorioretinitis is actually the most common presentation and is typically multifocal, often associated with shallow RD and some vitritis. So we'll begin with some of the classic presentations of syphilis. So here in these series of pictures, we have the very, very classic acute syphilitic posterior placoid chorioretinitis. So as you can see, uh, there is a active non-elevated placoid yellowish outer retinal lesion involving the macula. And then on fluorescein angiography, you can see that there is a localized hyperfluorescence delineating that exact area with leakage emanating from the lesion, and here associated with some optic disc leakage as well. So this is, I think, one way for you to differentiate the lesions of syphilis from the lesions of AMP or other white dot syndromes. So if those lesions associated with the white dot syndromes usually have a fluorescent pattern that block early and stains late. But in contrast, in the lesions of syphilis would show relatively early hyperfluorescence. All right. So shown here is another picture of a placoid lesion. So again, showing you multiple pictures because this is really the classic presentation of syphilis in the eye. So there's this placoid lesion along the superior-temporal arcade, and then the fluorescence pattern again shows the early hyperfluorescence, and here again associated with optic disc edema. Sorry. So the last picture shows you an ICG angiography, which shows you the uh, blocked fluorescence from the ICG. Okay. So that's for the acute posterior placoid retinitis. So another very, very common presentation of syphilis would be just retinochoroiditis. So here you see in the box are the confluent areas of retinochoroiditis presenting as triangular lesions. And the key word here is that they have sort of a ground glass appearance. So sort of like a stained window. But the way to sort of think that, oh, this could be a syphilitic lesion would be the associated superficial pre-retinal precipitate. So some uveitis specialists would define these as some creamy white dot. So as you can see here, there's the white ground glass lesion, and then on top you can see the dot. And on OCT, this would actually show hyperreflective round foci on the surface of the retina. So they are, and then they can even migrate over the inflamed retina. So they are pre-retinal lesions representing inflammatory cells. Okay, here's another picture of presentation of syphilis. And here you can see again the areas of retinal whitening. And if you sort of take a look at this, you would, some may confuse this as sort of a necrotizing retinitis, because you can see here there's some sort of retinal whitening in the periphery. And that's also one of the common presentations of syphilis, which is it's just an isolated retinitis. And then here on the FA, you can see the widespread retinal vasculitis with optic disc leakage as well. Another, again, another not uncommon presentation of syphilis would be optic disc swelling. So here you have optic disc edema associated with some subretinal fluid and optic disc leakage, and the classic visual field defects found in patients with optic disc lesions, which again, you might think that this might be a case of optic neuritis, but it's again one of the not uncommon presentations of syphilis. Nowadays, we diagnose one of the classic findings of syphilis on OCT would be these little bumps or RPE granularity. So whether it be the placoid lesion or the retinochoroiditis lesions, most OCTs would show these little bumps, and these represent again some inflammatory reactivity of the RPE to the treponema pallidum spirochete in the retina. So if you see these little, in any disease, if you see these little bumps in the RPE, you should really think of syphilis. Okay, here's another picture showing you that focal subretinal fluid can occur again and with associated mild signs of macular edema. But in this OCT, you can still appreciate these little bumps or granularities in the RPE, which are really, really characteristic of syphilis. Luckily, so these bumps and outer retinal changes represent changes in syphilis during the active stage of syphilis, but these actually resolve remarkably following treatment. So here you can see an OCT of a patient before and after treatment for syphilis, and the lesions disappear without any trace. One new modality that's now gaining extreme popularity in the management of uveitis is fundus autofluorescence. So you can tell that an image is an autofluorescence by looking at by looking at the disc, because there's some confusion as to whether an image is an autofluorescence or just a red-free image. So just a tip is that you take a look at the disc, and if the disc is black, that's usually an autofluorescence image. So if the disc is gray, and then the vessels are white, usually red-free image lang yun. So here you have an autofluorescence of again another syphilis case, and in autofluorescence, active lesions are white, so they are hyper autofluorescent. And as you can see here, if you just look at the fundus, you would think that there's really not much going on. But if you do an FAF, you can see that there's large areas of hyperautofluorescence representing active inflammation in both the right and the left eye. And then this is confirmed by angiography showing you the optic disc leakage and the localized vasculitis in that area. But if you compare the FA and the FAF, you would think just by getting an FA that the inflammation just localized in the macular area, but in truth the inflammation is localized up to the periphery, as you can see in the FAF. Again, to highlight another important pearl in getting in interpreting FAF. So active lesions would appear white, hyperautofluorescent. So it's like in this photo, you can see the white lesions representing lesion activity. In a case of retinochoroiditis on the left, and then on the right, you can see the white, well-delineated area representing the area of placoid retinochoroiditis. Okay. So this table, I think, is a nice summary of the imaging features of the retinitis lesions in syphilis. So pardon the very busy table, but so just to summarize, so placoid outer retinitis, as we discussed earlier. So there's the placoid lesion that's hyperautofluorescent. And then on OCT, you can see the elevations of the RPE and the outer retinal loss. But the nice thing about it is that it resolves without pigmentation or without any permanent marks on the retina. This is opposed to chorioretinitis lesions, which may appear which when they resolve, they pigment. So parang minimimic na niya yung other retinitis lesions like toxo. And then you can also have choroidal lesions, uh, mimicking the lesions of, let's say, tuberculosis or sarcoidosis. And they would resolve in the same manner, so scarring pa rin. So really the lesion here that is really pathognomonic for syphilis would be the placoid outer retinitis, and then the other lesions are just other ways in which syphilis can present that mimic the classic appearance of other diseases. Okay, so we move on to the diagnosis for syphilis. So once you see a patient, for example, with the usual risk factors, maybe the typical history of a rash or a chancre lesion, you now move on to testing for syphilis. So, so when testing for syphilis, so babalik tayo sa IM knowledge natin. So we have the direct test. So that's the dark field microscopy or the cultures where you try to directly diagnose the organism involved. But culturing spirochetes is actually very difficult and not practical. So the main diagnosis of syphilis is mainly reliant on the indirect test or the serologic tests. So for the serologic tests, these basically we are testing for antibodies to syphilis or syphilis-like molecules. So roughly we have the non-treponemal tests and the treponemal tests. So for the non-treponemal tests, the more common tests that we know of would be the RPR and the VDRL, which you can both have qualitative and quantitative tests. And then you have the treponemal tests, which include the syphilis EIA, which is now the standard for testing syphilis. And then you have the more conventional tests would be the FTABS, MHATP, PPHA. So I'm sure everyone is familiar with those tests. So for the diagnosis, I'd like to discuss this. How do you test for syphilis? And this would be interesting later that we can ask Dr. Ong Hansen what he does. So there's a traditional algorithm and then there's a reverse sequence algorithm. So um, traditionally, you would do, and this is the way we are taught in med school, that you do a non-treponemal test first. So that is an RPR or a VDRRL. And then depending on if it's positive or negative, you would proceed for a confirmatory test. For a confirmatory test, because as you know, the non-treponemal test would be very non-specific for syphilis. So that's why you need a confirmatory test. That is the FTABS, MHATP, or syphilis ELISA. So when the RPR VDRL is reactive, you proceed with the treponemal test. And depending on the result of that test, that's where you will treat or not treat the patient as syphilis. So nowadays, the CDC has already, the United States Centers for Disease Control has already proposed a reverse sequence algorithm where you actually start with a treponemal specific test. So ideally, this would be the syphilis ELISA, enzyme immunosorbent assay. And then, depending on the result of that test, you are already positive or negative for syphilis. And then you do non-treponemal test. So the RPR or VDRL. Uh, I personally, well, for uveitis, I think the reverse sequence algorithm is more applicable to us, and this is the reason why. Because when you first get syphilis, so you have an increase in the antibody titers for both the non-treponemal test and the treponemal tests. So, but as you can see, as time goes on and you progress to the latent stage of syphilis, usually the non-treponemal antibody, so that is your VDRL or RPR, can wane. But the FTABS will remain positive for life. So, if syphilitic uveitis does occur in the latent stage, that is to say, when the patient does not have any symptoms, if you just do an RPR first without doing a treponemal test, you could miss these cases of syphilis kasi bumagsak na yung RPR titer by then. So that's why for uveitis, I think it's more prudent for us to do a treponemal test first. Uh, for confirmation kasi the RPR might be negative already by the time we see the patient. Okay. So of course there are pitfalls in testing. So you can get false positives for both the treponemal and the non-treponemal testing. So for the non-treponemal testing, so you can get transiently positive results in pneumonia, malaria, tuberculosis, if the patient recently underwent a vaccination, or if the patient uses narcotics, and you can get permanently elevated RPR, or VDRL in some cases of SLE, leprosy, and even advanced age. For the FTAABS or the treponemal test, you can get false positive result in cases of SLE, rheumatoid arthritis, basically autoimmune conditions and biliary cirrhosis. So these false positives tend to persist for a patient's lifetime, and they likely represent the antibodies that coincidentally cross-react with the treponemal antigens. So the testing is not perfect. For sure, many of us get results uh, like weekly positive FTABS, and we don't know what to do with that. So usually what's done is you can, since there are many tests for syphilis, so just to review, that there are many tests. If there is one test that is in doubt, for example, you get a weekly positive FTABS and you don't know what to do with it, you can supplement your testing with another syphilis test. So you can order another treponema specific test like EIA with to sort of help guide you if it's really positive or it's just a false positive. Okay. So we move on to the final part of the discussion, which is the treatment. So penicillin has been the mainstay of treatment for syphilis since the 1940s, and it's still the most effective treatment up to this day. So there are two regimens used in syphilitic uveitis. So most uveitis specialists would consider ocular syphilis as a neurosyphilis. So therefore, we use the neurosyphilis regimen, that is to admit a patient and give intravenous aqueous crystalline penicillin G 18 to 24 million units per day, given as 3 to 4 million units every 4 hours for 10 to 14 days. But there are some specialists who would treat this as a latent syphilis instead, because most uveitis cases do present as latent syphilis. So in treatment ng latent syphilis would be intramuscular injections of penicillin once weekly for 3 weeks. And you would also read some regimens that would combine the two. So give the IV treatment for 14 days and then give and then supplant it with intramuscular injections for to complete 3 weeks. So iba-iba, but most would recommend the neurosyphilis regimen of IV treatment for 14 days. So if the patient does have an allergy to penicillin, there are some alternative regimens, experimental regimens. So that would be ceftriaxone and doxycycline. So the doxycycline one, doxycycline 200 milligrams BID for 28 days actually gained a lot of popularity during the COVID period where patients didn't want to get admitted, so they would just opt for oral treatment. It has been successful in some cases, and you would read a lot of reports showing that doxycycline is effective. But just know that if the patients fail on the alternative regimens, you would still go back to the penicillin treatment because that's the established treatment for syphilis. And it's so effective to the point that if you do have allergy, some would even recommend for you to be desensitized first to penicillin so that you can receive penicillin. So steroids is of equal importance in the treatment of syphilitic uveitis. So as with the treatment of all infectious uveitis, so you have to treat with the appropriate antimicrobial therapy, since treating with steroids alone has the potential to worsen the disease activity. So you may start as early as 2 to 3 days after initiation of antibiotics, and the purpose of the steroid is to limit the damage to the ocular structure from the host immune response, and also to prevent the occurrence of a gyrus Herxheimer reaction. So this is when you start the antimicrobial treatment, and because of the dying spirochetes sort of elicit a host response. So you can the hallmark of this is worsening vitritis or new vitritis after you initiate treatment. So the steroids should help with that. And the steroids do help also in resolving all of the uveitic lesions that we saw earlier, the vasculitis, the RP granularity. So just a side note for for HIV patients, since again, HIV and syphilis are like brothers, they occur together in a lot of patients. So the infection runs a more severe course and can require a longer course of treatment for adequate cure. So the presentation is similar to non-HIV patients. So there's no unique presentation in HIV patients. Maybe just that the lesions might be more large or more widespread, and the inflammation might be uh, altered because of the altered immune response. But the thing to remember in these patients is that there is increased risk of relapse despite the high dose penicillin therapy, and that they are slower to seroconvert from a positive to a negative RPR despite treatment. So that's important to remember. And I guess in these cases where there is co-infection with HIV, it's already prudent to involve our infectious disease colleagues, since they might be more knowledgeable in the management of co-infection. So this is the last slide. So as a summary, syphilis can present in various forms. So it's the great imitator, and it's important. And because of this, it's important to test for syphilis in all patients with uveitis. So um, for uveitis people, it's actually um, I don't know about uh, Neil, but it's actually a sort of a relief if we find out a patient has syphilis. So at least it's syphilis, because syphilis is actually one of the curable causes for uveitis. So once you give the IV penicillin and you can see all of the lesions resolved, usually the patients only need treatment with steroids maybe for about a few months, and then we can consider their uveitis cured already. So this is opposed to autoimmune uveitis, where patients would need many, many years of treatment before a durable remission is achieved. So syphilis is one of the curable causes of uveitis, and I think this is important to tell our patients so that at least there's a bright side to getting diagnosed with syphilis. And that's the last slide. So thank you for listening.
Thanks so much, Albert. Actually, I agree with you. I always tell my patients then, if it's syphilis, they'd better pray for it because it's really easy to treat and it's really fast compared to the treatment that we do for other diseases. Are there any questions from the group? or from the residents regarding ocular syphilis? See Trisha. Trisha, what's your question?
Hi, Doc. Thank you for that lecture. I was just wondering, kasi diba parang traditionally we're taught that once it's ocular syphilis, it's already tertiary syphilis. But you mentioned also that the most common time it presents is during latent syphilis. So I was wondering if that like what we're traditionally taught still holds true, or is it just for treatment na if it's ocular syphilis, we treat na din kasi as neurosyphilis?
Yeah, that's a good question. So, I think that yung notion na yun that ocular syphilis is tertiary syphilis comes kasi from the fact that we treat it as neurosyphilis. So, neurosyphilis diba, is considered a form of tertiary syphilis. Um, but the literature has shown that the most common time that it occurs is actually during latent syphilis. So, but again, it can also occur in secondary or tertiary syphilis. Uh, but the most common presentation is in latent syphilis. But we treat it as tertiary syphilis. So, baka doon nanggagaling yung confusion.
Thank you, Doc.
So yun, actually in relation to testing, Albert, I do have a question for that. How high is your clinical suspicion for it? Let's say you have a patient na you did multiple tests, MHA, and you also did an FDA. One is negative, one is positive. Would you be more considering a false positive or a false negative?
Mm. Ako ay mas tiniligan ko yung treponema test eh. So if the treponema test is negative, I would be more inclined to say negative siya. Even if the RPR is positive. Kasi yun nga, mas specific kasi yung treponema test eh. But one thing na parang, shall we say, nakakainis nowadays is when you get these tests na weekly positive yung
Mm-hmm.
when you order an FDA ABS and it's weekly positive. So that's when more dilemmas come for me kung syphilis ba to or hindi. So yun na nga yung what I found useful to move forward para so that I don't have this sort of thinking that it's the syphilis in my head is to order another test. That's not the same test. So that would be a syphilis ELISA or a treponemal ELISA test. And if it's negative, then okay, then I would consider the weekly positive as sige, baka hindi talaga siya syphilis. But if it's positive, that increases my resolve to treat as syphilis. Ikaw ba, Neil? How would you resolve yung mga dilemmas na ganun?
Actually, exactly the same thing. Because I've been having some patients na weekly positive yung FTA or even negative or even straight up negative na positive yung partner. When I test them, I usually like using MHA and TPPA as my next step. I don't know kasi if ELISA is available readily because my patients often can't find it. So nahanap ko is actually nagpa-positive sila sa other tests. So yeah, in those
Mm-mm.
cases, I still advise admission.
Yeah. Sa high precision ba ito? Or ano, is it
High
available in
precision,
Makati
alam ko
Med?
lang EIA eh.
Yeah, so parang yeah, I guess you have to ask the hospital what the tests are. The syphilis ELISA I sometimes find incidentally lang sa mga hospitals that they have the syphilis ELISA or EIA. But yung MHATP is a bit harder to find. Where do you have it done?
Actually, MHA and the TPPA is readily available in most high precision.
Ayun.
So I have the opposite
The,
naman problem with you. ELISA yung nahihirapan ako.
The main problem with these tests, yung mga conventional tests, is they do take a long time for the results to turn in. So, diba, usually around 1 to 2 weeks for an FDA ABS to turn in. So, sometimes you get these patients following up that already have all of the tests that you ordered, pero they will say na the FDA is still in process, and that can be a bit of a frustration.
Definitely agree. But in cases where I have high clinical suspicion, I would not start treatment until with result ng test. Kasi the damage is
Yeah.
usually not done that quickly naman.
Yeah, definitely. You do. I do agree. Na you do need a basis for why you're treating it. So you need a laboratory diagnosis.
Actually, I do have one more question for you, but before me, does anyone else have a question muna for Dr. Bromeo? Albert, one more question lang. I'm sure naman you've encountered syphilis in HIV patients. Are you also encountering that they have more unusual test results? Yung mga tipong indeterminate or even negative despite having positive partners? Kasi
Mm,
ako sa HIV, I've been testing, I not just test them, I also test their partners. So I've been getting
mm,
cases, I've had some cases where natetest ko yung partner nila, uh, positive syphilis testing yung partner, negative syphilis testing yung may uveitis. And then, I've had cases nung na-treat ko na okay siya in HIV patients.
mm. Ako wala pa ako na-encounter na ganun. Uh, but that's definitely possible. We know naman na medyo uh, derailed yung immune system nila, so they can have parang weird serology. So I guess, but the thing kasi diba with HIV is you really can't rule out co-infection.
Yes,
Again, pwedeng yung nakikita mo, kahit na mukha siyang syphilis, pwedeng TB pala siya or pwedeng herpetic lesion pala siya that's presenting in another way because the immune system is altered. So that's yan yung medyo mas challenging sa HIV. But ako, I haven't
definitely.
encountered, luckily.
Yeah, yeah. We get a lot of weird things. So Albert's also joining us in East Avenue Medical Center. You're gonna see some really, really weird patients over there. Does anyone have any questions for Dr. Bromeo? For our residents, you've been encountering quite a few syphilis cases throughout the year. Um, during yung yung regular day, yung regular visits, no, yung regular monitoring, Dr. Albert. Aside from yung standard RATD, color vision, central vision, what do you usually test your patients for? In order to see improvement, or is it just the vision that you look for?
Oh,
And how early pala do you
no.
expect your improvement?
So, depending on the initial presentation, kasi as you mentioned nga, iba-iba yung initial presentation niya, 'di ba? So for example, if they present with the chorioretinitis lesions, the more important thing would be kahit just a photo and then OCT sa mga follow-up kasi you want to see first the chorioretinitis lesion getting smaller, and as well the return of the normal architecture of the outer retina and the disappearance of those little RPE granularities on OCT. So at least a photo and an OCT. But if you do have an autofluorescence, that would be very, very nice. Kasi yun na nga, parang it shows you the chorioretinitis lesion in much greater detail than just a normal photo would. So photo OCT, but if I did have FAF, mag-FAF ako. But again, it depends on the initial presentation. If your initial presentation was retinal vasculitis, and ayun, may mga I did have a patient before na na retinal vasculitis yung presentation niya, then you would have to do an FA. Repeating these diagnostics every 2 to 3 months would be quite reasonable, I think.
Thank you so much for that. Dr. Paulino, do you have any Dr. Paulino's our RTO, Dr. Valero, our chair is not here at the moment because he's abroad. Dr. Paulino, you have any words to say?
Thank you, Albert. Hello.
Yeah,
Thank you for the lecture. So we're
all
looking
right.
forward to welcoming you to the department soon. Si Neil na ang bahala.
Oh yeah, I'm working with Adelna to make sure that Albert gets in already. So we also have a sponsor, no? May ano ba? May presentation or something yung sponsor?
Yes, Neil. So, for a quick presentation, we welcome Mr. JD from iMart.
Hi,
Uh,
Doc.
do you have a slide to share, sir?
Yes, Doc. So, nakikita ba ako, Doc?
Dr. Albert, can we unshare the slide so that, yeah, thank you.
Hi, Doc. Hi, doctors. I'm JD again from iMart PH. Your doctor engagement manager. And currently, Doc, I'm not the usual medical representative who will be presenting you today the product itself. But this is what I'm gonna present to you right now. We have the introduction for what is an iMart.ph. So I'll just share my screen now. So doctors, iMart.ph is the first and only e-commerce site designed by ophthalmologists and suppliers to reach the promotion gap and address the supplies between ophthalmologists and suppliers in the Philippines. So basically, why this kind of promotion, doctor? Because everything now is digitized, and we want to have that kind of technology as well. And we move forward in terms of managing the supplies for our ophthalmologists in an easy access process. How are we going to do that? By just simply a single access to different products from different suppliers. We also have we do have the MTC, the tops, and the Visant currently, which is we will be live by tomorrow, which is beside the distributor of Medicontor, iMed Pharma, and Miran. So basically, we have the 5% off as well for that for launch sale. And then we also digitalize the purchasing process, more efficient, safe, and convenient. Why I do say so? Because in terms of this safe, basically, Doc, alam niyo naman yung mga Lazada, Shopee, yon. We do also have that kind of safety features in terms of your managing your purchases, as well as you will be the one paying it online as well. So we also do have 24/7 ordering and customer service availability. And lastly, it will gain more access to product information and payment option because you can always review your product, your purchase product in your own safety home. So basically, doctors, with a growing number of needs and cases for eye diseases, we should expect more innovations and new technologies on the rise. So we want our dear ophthalmology doctors to engage with a new normal by just simply accessing it in a platform where it will be just as simple as buying water in a convenience store and be on the go. So basically, doctor, this is a website, not just, we are not yet a mobile app, website pa lang po siya. So doctors, bottom line, iMart PH offers access to all products, Opta products, doctors. Conveniently purchase the products in your own comfort place. Digital benefits by having special deals and vouchers you can apply. Time management, we're just simply clicking on the site and checking out what to order in just minutes. So basically, doctor, when you scan this QR code, you will be going to this site, doc. This kind of site. So you will just sign up first. All we need to do is just sign up. Place your email address, your name, your mobile number, your birthday, your address, your hospital affiliation, and your PRC ID. Then also with this doctor, you have to also put your or upload your PRC ID so that we can be able to verify if the PRC number that you've placed there is the same as the one that you have on your PRC ID. In that way, we will be verifying. That's the safety feature that we do need to have. And then also afterwards, doc, makakarating naman kayo sa ayan, Doc. So, yan yung mangyayari. And then afterwards, you will be able to receive an email coming from us just to verify na kayo nga talaga yung nag-sign up. Afterwards, Doctor, there will be a link there that going to the site itself para makapag-ano kayo ng password and username ninyo. So basically, doctors, these features benefits more onto you because it will have safety features that only ophthalmologists have access on it. So, yun, Doc. And then, as what I've mentioned, MTC, we have TOPS, we have the Bisant, will be launching tomorrow. As of this October, we will be getting 2 more as well suppliers, and then November, coming November, we are talking to some suppliers as well. So October, November, we will be launching suppliers as well. So you can also like our page, our Facebook page, imart.ph, so that you will be you are actually updated in our suppliers. And then, of course, imart PH is vision finally to be seen clearly for an evolution of digital marketing design by ophthalmologists and suppliers for ophthalmologists and suppliers. So this is the first and only eye care e-commerce site for ophthalmologist doctors. That's basically it, doctor. It's just as simple as imart.ph lang. And then just scan the QR code, doc, para makarating kayo sa ating sign up page. That's basically it, doc. Thank you very much. By the way, doctor, thank you very much for letting us participate in this this session, doc. And we do have also in the panel my dear president, Miss Nina Rojas, if you know Nina. She used to be my product manager way back before. So, sandyan din siya. Ayan.
Hello, everyone, and thank you for having iMart.
Yeah, thank you very much, Doc.
Thank you so much,
Thank you.
Sir JD. So I think that's the end. Neil, do you have any other message? Thank you, Sir JD.
Thank you.
I think
Well,
they will
looking,
be in the annual Congress this
Yes, we will.
December.
We will.
Okay. So even IOLs, I think it's available in
Yes, Doc.
iMart.
Sorry for that. Yes, IOLs. We have also the equipment space with the TOPS and FTC. IOLs, also with the eye drops that we do have for design.
Okay, thank you. So Neil, any other announcement? Our next department conference with uveitis will be on the 27th. So next week, the residents and the entire department will be busy because on the 21st will be our postgraduate course. Dr. Levin will be with us starting Friday. So if anyone meets him in A&E, in SEDA, or in the OPD, feel free to interact with him. Okay. Thank you so much. Have a good afternoon po.
thanks everyone for attending.
Sir, thank you. Unfortunately, Doc. Okay.
Ay, sige, kasama na. Ang laki. War. Wait. 1, 2, 3. Okay, wait lang po. Bakit may naka-zoom pa? Okay.
Thank you. Thank you, Doc. Thank you, sir.
Ayan.
Malas ko na.